Hello, my name is Colin Coyne, and as Executive Director of Meta Global, on behalf of all of my colleagues, we'd like to welcome you to this important and timely video presentation. Meta Global is a global education service provider that seeks to connect practitioners, educators, and institutions to deliver a transformative model of healthcare education. We seek to improve the outcomes of populations by providing access to globally renowned faculty in a way that addresses present and future needs and through the lens of competency, character, and caring. The series you're going to view today addresses the essential topic of cardiac complications from COVID-19. The series is divided into 6 parts, which can be viewed individually or consecutively as one seminar. We'd like to thank our partners at Brookwood Medical Health Systems and Dr. Farrell Mendelsohn for providing access to this content. We hope that it adds to your practice. We hope you enjoy the presentations, and we particularly wish you continued good health.
Hello, I'm Dr. Donald Lloyd-Jones, President of the American Heart Association for 2021 to 22. I'm also the Chair of the Department of Preventive Medicine at Northwestern University in Chicago. This presentation from the Cardiology PC Group in Birmingham, Alabama, on the CVD impact of COVID-19 should be very useful to you in your practice. I am so pleased that my former colleague from residency, Dr. Farrell Mendelsohn, was able to organize this series of presentations for your benefit. All the best to you and others in Asia as you continue to manage the COVID pandemic and the growing epidemic of cardiovascular disease. Enjoy the meetings.
Well, greetings everybody. My name is Farrell Mendelsohn. I want to first thank Dr. Hutton Brantley, who has put together this incredible program for y'all today on cardiovascular complications of COVID. He's been running this program for many years, and I think it's a wonderful service to our medical community. And this year he's spearheaded the effort to take this program and broadcast it actually to our friends in China. We've trained over the last decade over 100 interventional cardiologists and many nurses in China, and we're going to be taking this program and doing it as a broadcast to our friends over there. And so I want to give a greeting to our dear Chinese colleagues and hope that the program today is going to be valuable for them as well. And I'm following Dr. Sibley's talk, which was really fascinating discussion of ECMO, and he has really spearheaded that effort here at Princeton, and the results that he's talking about are incredible. And my hat really goes off to him on the incredible work that he's done to save so many patients who are fighting for their lives. I'm going to talk this morning today about acute ischemic stroke and acute ischemic stroke as a complication of COVID-19. The great majority of my talk, though, is going to be actually focusing on stroke itself. I don't have any financial relationships to disclose about this topic. So let's just start with a few stroke statistics. There are 700,000 acute ischemic strokes in the United States each year, and early mortality was 10% before the modern treatments became available for this devastating disease. And among those who survived, really half had moderate to severe neurologic deficits. So as we all know, stroke it's a deadly disease, and there are really 3 key clinical parameters when you're taking care of the patient with a stroke. First off, when did this stroke start? That's going to be critical to know and is going to influence the therapy that you're going to be able to provide for the patient. How bad is the neurologic deficit? And what are the findings on neuroimaging in the particular patient who's having a stroke? These three key clinical parameters are going to guide how you take care of the acute ischemic stroke patient, and we're going to go over each of these in detail. So how do we time the stroke onset? Time from stroke onset is when was the patient last known well. So interestingly, if a patient wakes up from sleep with a neurologic deficit, the last time they were known well is when they actually went to sleep. So this is a very important parameter. When did the stroke start? That gives you a time frame of how long has this deficit been going on. Second key clinical parameter is how bad is the stroke? What is the severity of the neurologic deficit? There are a lot of different scales to use to grade that, but the most commonly used one is the National Institutes of Health Stroke Scale. This scale, outlined over here in the figure, gives scores of 0 to 42, and the lower numbers being milder deficits. It's important to characterize the stroke as, is it disabling or is it not disabling for the patient? So if it's disabling, the deficit would prevent the patient from performing the basic activities of daily living or interfere with their ability to return to work. And then finally, and this is very key, what types of neuroimaging are we using in these patients, and how do we interpret them, and how are they going to guide our treatment of the patient? And we're going to go in each of these, we're going to discuss each of these imaging modalities in greater detail. First off, non-contrast CT, just a simple head CT scan that's going to be done as rapidly as possible. Main purpose of this is to rule out an intracerebral hemorrhage. So we're talking in this talk today about acute ischemic stroke, not hemorrhagic stroke. So if the patient has hemorrhage on the non-contrast CT, that's a different management pathway that we're not going into today. Secondly, CT angiography. This is going to localize if there is an intracranial artery occlusion, a large vessel occlusion. Very important in terms of guiding the management pathway. And then finally, and we're going to spend a little bit of time on this, perfusion CT scan of the brain. This technology is really very exciting, and it's able to define ischemic brain tissue that is irreversibly damaged. That's the core infarct. And also define areas of brain that are potentially salvageable, the ischemic penumbra. Now let's start off with the basic non-contrast CT. This is the first imaging modality that we're going to do in the acute ischemic stroke patient. The stat head CT here, it shows no evidence for hemorrhage. And as you can see over here, this is an example of an intracerebral hemorrhage. You see this on the first, on your scan of the acute stroke patient. They're not going to be a candidate for thrombolytics or mechanical embolectomy, which we're going to get into later in the discussion. So this type of patient is going to be managed in an entirely different fashion. But this is the most important first imaging step that really leads you down one of two paths for the care of the patient. Next is CT angiography. Here's an example of a normal CT scan. This is the left middle cerebral artery, left anterior cerebral artery. This patient has no evidence for a large vessel occlusion. This unfortunate patient here, as you can see, the left middle cerebral artery is cut off. This is going to be the type of patient who may be a candidate for mechanical embolectomy. So this CT angiography is the second step in terms of neuroimaging of the stroke patient. And then finally, a form of CT angiography that you may not be that familiar with is perfusion CT scanning. Perfusion CT is a form of CT angiography, but it uses a computer algorithm that samples contrast in the arterial and venous regions of interest. It then, from these samples, it derives flow parameters that define an infarct core and an ischemic penumbra. And I'm going to show you an example of this. This is the kind of data you get back from a perfusion CT. Now let's just delve into this in a little bit more detail. So how is the core infarct defined on perfusion CT? Well, using the parameters that we talked about, the neuroradiologist is able to determine regions of interest where cerebral blood flow is less than 30% of normal. That's the core infarct. As you can see here, it's pink or maybe magenta on your screen. This is what is highlighted as the core infarct. Cerebral blood flow less than 30%. Now the ischemic penumbra, or the region of the brain that may be salvageable, is defined as a Tmax, or a time at which contrast density peaks after 6 seconds. That's over this, in this part of the scan, highlighted in the green. Now, the core infarct and the ischemic penumbra are presented in terms of volumes and reported in milliliters. So as you can see in this particular patient, this looks like this patient is having a right MCA stroke. The region of the core infarct is the cerebral blood flow less than 30%, and that volume is 79 milliliters of brain tissue is having core infarct. This ischemic penumbra in this patient, remember defined as that Tmax greater than 6 seconds, the volume of ischemic penumbra is 298 milliliters. So why is this data important? Well, this helps us guide which types of patients may be a candidate for mechanical embolectomy. So we are looking for patients where the core infarct is small, with a cerebral blood flow volume of less than 70 cc's or milliliters. We're also looking for patients where the mismatch volume is significant. And what does that mean? That means where there's a lot of ischemic penumbra and not much core infarct. In other words, there's a lot of salvageable brain in this patient. So mismatch volume is defined as penumbra minus the core. Also, another way of looking at that is mismatch ratio. And we use a cutoff of greater than 1.8. That's the penumbra divided by the core. Both of these measures really just give you an idea of how much salvageable brain is there relative to the core. So for example, if the entire infarct is essentially core with minimal ischemic penumbra, that's unfortunately a patient that we're not going to really be able to help very well. Now, what have been the landmark therapies to treat acute ischemic stroke? Essentially, intravenous alteplase or TPA and mechanical thrombectomy or embolectomy have really transformed the care of the acute ischemic stroke patient. And I'm going to talk a little bit about what are the types of patients who are candidates for these two therapies. Now remember, we talked about the key clinical parameters, those 3 bits of data. You know, what is the duration of the stroke or the time of onset? Is the stroke disabling? And was there any evidence and what were the findings on neuroimaging? Again, we're coming back to those 3 clinical parameters that we talked about at the beginning of the talk. So what kind of patients are going to be a candidate for TPA? Well, they need to have had the stroke onset within 4.5 hours. The stroke needs to be a significant stroke or disabling. In other words, if somebody has a very trivial, minimal facial droop, you're not going to want to expose them to the risk of an intravenous thrombolytic that could convert the stroke to a hemorrhagic stroke if they're not really having a significant deficit. And then finally, the neuroimaging findings. If the first CT scan, the non-contrast CT, shows hemorrhage, they're not a candidate for this therapy. What about mechanical thrombectomy? What types of patients or stroke patients are best suited for that? Now look at this time of onset. This is very important. Patients out to 24 hours from the onset of their stroke may be a candidate for this therapy. This is a dramatic increase in the time frame relative to the patients who are candidates for intravenous TPA. But let me make no mistake, the sooner that you treat patients with acute ischemic stroke, the better. So even though patients are candidates for this therapy out to 24 hours, if you can provide the therapy in a very timely fashion, patients do better. Again, is the stroke disabling, as we talked about with TPA? You're not going to put the patient through this therapy, which has its own risks, if they're not having a significant or a disabling stroke. And then finally, what are the neuroimaging criteria that make patients a candidate for mechanical thrombectomy? So let's go a little bit deeper into these neuroimaging criteria, but first I want to show you an illustration or a cartoon of how mechanical thrombectomy is performed. So here we go. Here's our stroke patient. Whoop, see. They've come in. You can see that's the clot that's in the brain. We've passed a wire across the clot. This is a microcatheter we've put in. Again, these techniques are very similar to the techniques already used in interventional cardiology. Here is what's called a stent retrieval device that was inserted in the microcatheter. Microcatheter is withdrawn, and this, unlike a regular stent, this stent is connected to a wire, and it is used to retrieve the thrombus back into the guide catheter and to restore perfusion to the brain. This is a dramatic, life-saving therapy. Now let's look at a little bit of the data of how beneficial is mechanical thrombectomy for the acute ischemic stroke patient. Now there are numerous studies that have looked at this, and I'm going to just give you this one in particular, which is a meta-analysis from 5 randomized trials. And we haven't gone into this measure of stroke, but this is a modified Rankin scale that goes from 0 to 6. This talks about how disabling the stroke is. The key point is 0 is no deficit at all, and 1 is a minimal deficit. So if you're going to call your therapy a success in the stroke patient, we're really trying to get the patient back to their baseline with no symptoms or a minimal deficit. So these 2 outcomes are the key. 6 is death. So in this meta-analysis, this first line here is the control population of 645 patients. The second line is the group of patients that underwent mechanical thrombectomy. And look at this dramatic difference. We've got about 13% in the control population that end up with a minimal deficit. Almost double that in the interventional population. And we could go into study after study that highlights the dramatic benefits of mechanical thrombectomy. But I thought I would just share this one with you today to highlight the importance of this. Also, at the other end of the clinical spectrum, the risk of death is lowered with mechanical thrombectomy compared to conventional therapy. Now, what about acute ischemic stroke with COVID-19? I'm going to talk a little bit about this. Stroke etiology is related to immunothrombosis. That's that cascade of events that COVID-19 triggers. 0.9% of patients who are hospitalized with COVID-19 experience ischemic stroke, and this is a deadly disease with over 60% of patients who are admitted to the hospital with COVID-19 who have a stroke will die. Now let me talk a little bit about our stroke program at Princeton, particularly our carotid stent program. Many of our colleagues from China saw a lot of these cases. It's one of the, in my opinion, one of the top programs in the country using carotid stents to treat patients with atherosclerotic carotid disease. We started the program in 1999. We've been in multiple clinical trials of this therapy. Have implanted over 2,000 carotid stents successfully since 1999. Published numerous articles on this subject, and actually published a book on the management of patients with atherosclerotic carotid disease. So Princeton has really been a leader both locally and nationally on carotid stent therapy. We are hoping to expand our program into treating patients with acute ischemic stroke and moving from carotid stenting into the realm of mechanical embolectomy. The problem in the United States is there are a lot of acute ischemic stroke patients, and there are not that many specialties that are providing this therapy. Currently in the United States, the great majority of mechanical embolectomy treatment is offered by neurointerventionists from neurosurgery, neurology, and interventional radiology. But there's just simply not enough of those specialists trained to provide this therapy on a national scale. And as I mentioned earlier in the talk, if the faster this therapy is provided to the patient, the more lives are saved. So currently in the United States, if an acute ischemic stroke patient who is a candidate for mechanical embolectomy presents to a hospital that doesn't offer this therapy, they have to be transferred. And as you're well aware, that involves time delays. This is a publication that we did, though, that reviewed a half dozen programs throughout the world where interventional cardiologists with extensive carotid stent training began treating patients with acute ischemic stroke with mechanical embolectomy with outstanding results comparable to what has been reported in the historic literature. And we are currently trying to work with our national cardiology societies to further the role of the carotid stent trained interventional cardiologist in acute ischemic stroke management. So to conclude, acute ischemic stroke is a deadly disease with increased mortality in COVID-19 patients. IV alteplase and mechanical thrombectomy are the standard of care in selected patients. Cardiology PC plans to expand the role of interventional cardiology in acute ischemic stroke. And I'd like to just conclude with this figure. This is my dog Biscuit, and many of you know that I got married this year, and it's my lovely wife with me, but we thought we'd just show Biscuit. Can I take any questions? Thank y'all.
Pleased today to be bringing you a brief summary of what you've heard already in this good video presentation about acute ischemic stroke in the face of COVID-19. So ischemic stroke as a problem in Asia and in many parts of the world is a common cardiovascular problem. The mortality rate prior to the onset of modern therapy, including thrombolytic therapy and thrombectomy, was greater than 10%, and with large neurological deficits in many patients who experienced ischemic stroke. Some of the key clinical parameters in understanding what a patient's prognosis might be and what therapy might be useful for them in the event of acute ischemic stroke in the face of COVID-19 include the time of onset of the stroke. So importantly, the time of onset relative to the time that the patient arrives at a hospital where they can receive these modern therapies. And then the severity of the deficit that the patient experiences is important both in prognosis and in making decisions about therapy. And then importantly, the findings on imaging drive a lot of what we know about prognosis and options for care as well. The common imaging procedures that are used today in evaluating a patient with acute ischemic stroke, whether or not it's related to COVID-19, include non-contrast CT, CT angiography, and perfusion CT. These are available in many of the urban hospitals around Asia these days. So the two recent changes in therapy in acute ischemic stroke have really been life-changing for so many of our patients. So first, let's talk about intravenous thrombolytic therapy that can be administered in almost all hospitals where stroke patients are treated. It's important that the thrombolytic therapy be initiated within the first 4.5 hours of the onset of stroke symptoms, that the disability is sufficiently severe to require taking on the risk of thrombolytic therapy, and of course what's there on the imaging studies. And for thrombolytic therapy, it's extremely important that the CT be evaluated carefully to be sure that it's not a hemorrhage that's causing the stroke, but indeed it's an ischemic event. And then for thrombectomy, this needs to be done faster within the first 24 hours of the onset of symptoms, and this has really dramatically changed, and I think in Asia as in the rest of the world, thrombectomy will become an increasingly used therapy for acute ischemic stroke. So unfortunately, acute ischemic stroke, when it's associated with COVID-19, has a poor prognosis. It occurs in up to 1% of patients with COVID, and the mortality rate approaches 60%. So I hope this brief summary of acute ischemic stroke associated with COVID-19 has been useful to you in your practice, and I wish you well as you continue to care for your patients with COVID-19 and acute ischemic stroke. Thank you.
Greetings, my name is Dr. Charlie Sands, and I serve as chair of MedEd Global's advisory board. As an international medical education service provider, MedEd Global is excited to have provided this outstanding review of the cardiovascular complications of COVID. Our mission is to promote superior education and training for international healthcare personnel. I sincerely hope that this educational video has proven to be of help to you and your colleagues. If you'd like to discuss ways in which you can support or become a part of MedEd Global, our contact information will appear on the screen momentarily. Thank you for the opportunity to share this important information on the cardiovascular complications of COVID.